My name's Tom Morrow, and I'm the Chief Medical Officer for a company called Next IT. And this is my second year at South by Southwest. And a little bit of background is I've had about 20 years in the health plan side where I started and ran health plans. Worked for a disease management company for a while, worked for Genentech for 8 years, but during that whole time I've been studying population health. And I've been absolutely depressed by what's happened over the last several generations. And I wanted to put out a couple of bits of facts for you. Question first, because that's part of the fact. What was the healthiest generation that America has seen in the last 200 years? Current one, last one, just give me a date or whatever. Current one, okay. Who thinks current one? Some. Throw some other ones out, come on. By any measure you have in your mind. There are actual measures to do it, but I want to see your impressions. I'm sorry? Whatever way you want to define it. Okay. Anybody, how many think that's right? Okay.
One.
You got one.
You win the beer.
Come on. There's only two, so it's either you have to be dead now or born now. Come on. Who else? 200 years ago. Huh. Born in the 60s. You're all wrong. The actual healthiest generation you were almost right, but it overlapped a bit. The healthiest generation were my parents. The people who went through the Great Depression, not recession, and World War II. They were healthier by numerous measures, as measured by the government through what's called the NHANES data set, which measures a whole lot of functional as well as physical measures. My generation, which I'm a boomer, and in right about 6 weeks, I will pass the golden milestone of Medicare age, is the longest lived generation. But we're actually less healthy by measurements than my parents' generation. What's depressing me is that every generation from mine down will have less longevity and be less healthy. I've got 4 children, 12 grandchildren. So my children's generation will be less healthy and less long-lived than mine. Their children will be one step lower on both of those measurements. That's terrifying, because we have had absolutely unbelievable advances in medical care over my career since I finished medical school, and it'll be 40 years next year. We didn't have CAT scans, MRI scans. We didn't have catheters. The image that my daughter had, my firstborn, 40 years ago on an ultrasound looked like a piece of silly putty, okay? The drugs that we had for diabetes were 3 different classes. There was almost nothing to treat people with. But we actually were healthier 40 years ago than we are now, despite all the technology. Why is that? And it's that the question is pertinent to this discussion, because this discussion is going to be patient behavior or personal behavior. We are less healthy sequentially because of our personal behavior. So it's estimated right now that there are about 29 million people in the United States with diabetes, and most of those are diagnosed, but a good chunk of them, probably a third of them, are not. We also have an estimated 89 million people in the United States, which totals out to almost 130 million, or 120 million people totally, that have prediabetes or diabetes. And it's expected that by the year 2035 or 40, and it varies based on estimates, that 1 out of 3 people in the entire US will have diabetes. No one in this audience can even imagine the impact that that's going to have on our country. Diabetes is the absolute best model for early aging, And what we're seeing with that population that has prediabetes is that they're entering into Alzheimer's earlier, they're entering into coronary vascular disease earlier, they're going to end up in renal failure earlier, they're going to end up with eyesight problems and amputations earlier than any other generation of diabetics in the face of the earth. In 1977, 0.7% of the population had diabetes. Now, right now, today, it's right around 10.6 or so. So over the last 40 years, we have dramatically changed our habits because up until 77 at least, the prevalence of diabetes was less than 1% for the history of mankind. But now it's at 10.5 going to 30 plus. And some estimates put it at 50% by the turn of the middle of the century. So this group is a group of folks that are working on various behavior modification programs in a wide variety of places. And they represent some of what I see as some of the most innovative companies that I've seen at South by Southwest. And I'm going to leave you with a quote and let everybody else talk here. Man cannot discover new oceans unless he has the courage to lose sight of the shore. And that's what this whole meeting is about. And it's been fascinating to talk to some of the innovators here. Just amazing ideas and concepts, business plans, startups, products, etc. And I hope you've all had that experience. But we're going to talk a little bit about behavior change, and I'll let the rest of the panel introduce themselves. And your product.
Sure, let me do that.
No lecturing like me about, what we all did wrong.
I think we have just 5 minutes left after you. Anyway, this is Hossein Fakhrai-Rad. I am the founder and chief scientific officer of a company called BaseHealth. My background is in genetics. I had the pleasure to spend about 10 to 12 years of my life in the beautiful city of Stockholm, Sweden. So if anyone has any question in Swedish, I would be delighted to answer the question in Swedish. I think Tom talked about the problem that we are addressing. I'm sure many of you sitting here have a loved one or has a loved one who have one of those most common complex diseases like diabetes, stroke, or cancer, and we all care about that. We really want to help people to understand about our risk for those common complex diseases. So what we have been doing at BaseHealth for the past few years is to build a health analytics platform that comprehensively combines your genetic data with your lifestyle data, your medical data, and environmental data, and provide you with an assessment for over 40 common complex diseases. The moment you learn about your level of your risk for those diseases, we breaks down the risk factors for those diseases. Because at the end of the day, the diseases that we have selected to have on our platform are the ones that you can control. We just heard about the numbers that people are dealing with those diseases on a yearly basis. We know the incidence of those diseases are really high. But what is the problem? Now, is it because we don't have any technology to do that? About just a decade ago, doing genome sequencing would have cost us $10 million. And it took 2 years to complete the genome sequencing. Today, we can do this over a few days for a couple of $1,000s. There are 165,000 health-related apps out there. There are tens, if not hundreds, of those devices that can collect pretty much what we are doing on a daily basis. But, we are collecting a lot of information, but we need to use that data to help people, motivate people, and engage people to take care of their health. And I think personally, there is a lot of information related with the education of this, because it starts by me as a user, being a family member, taking care of my family, my physician, my employer, my insurance company. This is not a one-man show thing. We need to all be educated. Many people thought that if the genome gets sequenced, tomorrow I can treat all the diseases out there. This is not going to happen. It's not going to happen. It's in our hand by knowing what we individually can do for any of those diseases that we are concerned. And I would love to have questions when everybody has introduced themselves, because it's better to have a conversation rather than us four sitting and talking to each other.
Exactly. I'm Kirsten Karchmer, and I'm the founder and CEO of Conceivable. Conceivable is a fully integrated fertility wellness program that uses machine learning and very basic AI to create assessment and prescriptive solutions for women with infertility. In the US alone, there are 7 million women who are diagnosed with infertility. Currently, there are 1,000 board-certified reproductive endocrinologists. On average, in vitro fertilization costs approximately $15,000 to $30,000, and the mission of Conceivable is to create a solution that's as effective as in vitro fertilization at 1/100th the cost. In order for us to do this, it's a big endeavor to take on, but in order to do this, we have to help raise awareness for women about the fact that their menstrual cycle is a barometer of their overall health, and that women can learn. There's a lot of diagnostic information that we can glean from a woman's menstrual cycle that can help us to actually substantially increase her fertility. Like all the women in the room, you may or may not know this, but having even just a 26-day cycle instead of a 28-day cycle can make you up to 50% less likely to conceive than a woman who has a 28-day cycle. And some of the factors that can significantly contribute to that are lifestyle factors. And so a component of our program is helping to teach women the appropriate lifestyle and diet factors, and helping them to make those behavior changes. We've talked about a little bit about motivation, and I hope we can continue to talk about this. I heard someone speaking earlier this week, and they were talking about changing health behaviors. And she said, it's really hard because not very many people are excited about getting healthy. Like we are for a month after Christmas when we're fat and we can't wear our jeans anymore, or we're just sick from drinking too much and eating too much sugar. But just as a whole, we're not super excited about it. And so really using technology to help cultivate behavior change, we have to really figure out how to help people get and stay motivated across long periods of time so that they can make behavior changes that can not only help them achieve whatever health goal they're trying to aspire to, but also that make lasting and permanent effects. So I'll stop there so we have more time for discussion.
My name is Colin Anawaty. I'm the co-founder and chief product officer for Patient.io. We are one of the local health technology startups in Austin. Patient.io is effectively a care coordination platform, and what that means in layman's terms is we try to improve the engagement, communication that occurs between a patient, their caregiver, and their provider when they're outside of the four walls of care. And what a lot of people who are not in healthcare, like myself, refer to us as the WordPress for delivering healthcare content and clinical care plans down to the patient. We've taken more of a technology approach to building out what we think may help with transitioning health systems into a value-based system. And we do that by not focusing on content. We focus on the best way, the most accessible way to engage with the patient. We think most existing solutions have taken kind of a point solution approach, and they try to classify each and every one of you guys as one and the same. And if you look around here, you're all wearing different shirts. You all have different upbringings. You all have different cultural values, from the food that you eat to just how you value exercise. And so that's why we don't focus on content. We focus on trying to reach you, or to reach my mom, or to reach someone else in the best manner, the most effective manner as possible. And so that's essentially kind of our approach for Patient.io.
And the company I work for creates avatars. And we call them relational agents. That's what's used in the literature. Avatars, virtual health coaches, virtual health assistants, they're all the same thing. And think of it as Siri for healthcare. Siri has an issue, though. And I tested it last night just to see if it was still accurate. I asked it, I was outside of this area, it says, give me the directions to the JW Marriott. And it did. Magic. Popped up, precise directions. And then I said, what's on the menu at the restaurant? I don't know what you're talking about. So it doesn't hold into context previous conversation. And it's not really meant to. It's a single solution, a single answer. What NextIT is trying to do is take the information that's gathered from other sources, and yours specifically would be the most likely, and then over long periods of time try to make small changes in nudging behavior. The theories of behavior change are numerous. There's over 80 of them, and they've all been proven to be effective at changing human behavior in at least some subgroups. And there's some major ones that that have been the most popular, and you're probably aware of the trans-theoretical model that Prochaska used. The social cognitive theories are another whole class of theories, and the third one is the health belief theory. And these are all encompassing a lot of what's being used by the companies up here, where we first of all have to educate people on what their illness is or their condition, give them the best options for treating it, but then slowly over time treat it. I'm a physician, and I used to hand a prescription to somebody along with a list of instructions and say, hey, come back in 3 months. And you're saying that really doesn't work too well. You've got to give them a lot more care. So tell me a little bit about what you do. And please, other questions are welcome.
So in our program, we adhere to the same philosophy of really breaking down some of the larger behavior changes that we're interested in helping patients to have into very small steps. So really understanding that taking 12 to 24 weeks to make a behavior change and meeting patients exactly where they're at. So, we encourage our users to get 8 hours of sleep per night. So instead of telling you, like, okay, tonight you need to get 8 hours of sleep, right? Nobody can do that if they're only getting 4 hours or 6 hours. Actually, we have to provide a tremendous amount of education, especially relational education about, the relationship between sleep and fertility. I mean, we work with a population that's very unique compared to almost all the other behavior modification programs, because women who want to get pregnant will do almost anything to get pregnant. And so if we tell them, you need to do this, actually what we have is they do too much. They'll come up with a 48-page spreadsheet, right, to do everything. And that actually causes more stress, which is more injurious to their fertility. So we actually have to sort of rein them in using behavior modification so that they can make slow changes, so they're not just, downloading a bunch of information and trying to do it all overnight, which then doesn't tend to have any permanence.
So you've got another challenge. I mean, you've got people who really don't want what you're telling them. Have you ever seen any happy people saying that you're going to get diabetes or something like that?
Well, again, I just want to reemphasize on the fact that diseases that we are targeting are most common complex diseases. Again, stroke, heart disease, diabetes, gout, number of different diseases that are associated with number of modifiable risk factors, non-genetic risk factors. What we actually learn, I'm a geneticist myself, I should actually sell this today, but I'm not doing it. But what we learn by doing this genetic test, we learn if we have genetic predisposition for certain disease. What does that mean to me is, if I have genetic predisposition for diabetes, then when there is number of different modifiable risk factors for that disease, I have to be more careful taking care of those risk factors. So if my triglyceride is high, my blood pressure is high, if I'm eating too much red meat, then I have to be more careful because I have genetic predisposition. I actually come from a family with type 2 diabetes risk. My father, my grandfather, my uncle, my aunt, they all had type 2 diabetes. And I always ask this question, like, why not, if this is genetics at that age, I thought that if something is genetics, that everybody's just going to get it. But that's not the fact. Some diseases, if you have a variation in certain gene, for monogenic diseases, you're going to get it. But not in all cases. But let me just ask the audience a question. I know that the gentleman has a question, but how many of you guys have done a genetic test, a genotype in a whole genome sequencing?
Wow.
Not bad. Have you guys found that information useful or not useful at all? Okay. Because my colleagues, they call me and ask, I want to go and do this genetic test. I want to know really if I'm going to get, diabetes or Alzheimer or this and that. Then I'm saying that if you want to do a genetic test, make sure that you're doing something that helps you also to identify the modifiable and things that you can actually control. Because knowing you have a risk for a disease, but not taking any action for things that it's in your control, it's not really valuable. Many people do those genetic tests. They see those green charts coming up saying that you have protective effect of not getting this disease. That means that I can do whatever, I'm never going to get that disease. That's not the fact. That goes back to the education. Those companies who are selling those, they should say very clearly, this just helps you to be on a category of people that should take care of the risk factors that they can control more carefully.
Colin, can you comment on how you address these things?
Yeah, sure. So when you kind of described the way that you interacted with the patient, when you were practicing, which was you'd bang out a care plan, might be 2 or 3 pages about a person's disease state, about their medication, print it out, stuff it in a folder, and give it to the patient. That's exactly what we're trying to help solve as healthcare transitions from transactional to value-based care. It's no longer good enough to give a patient a piece of paper and send them on their way and say, come back in 3 months. Not under the new model, not under lump payments. And so why we focus on technology is both helping out the health systems with better structuring that data so they can report on it, but also it's a two-sided problem. The patient now needs to be accountable. We need to know a little bit more about what's going on in that patient's life, the 3 months that they're at home, hoping that they don't have a readmission penalty within 30 days, but also so that case managers and care managers can get more involved, and so that you're not turning to Yahoo Answers for self-diagnosis. And so that's where we see kind of core blocking and tackling within health systems that can go a long way. I think it's pretty silly today that a lot of health systems still operate that way when this phone is almost 10 years old. You can even go into a health system and pay for an unhealthy Starbucks or a Chipotle burrito and order it from your phone and pick it up, but your experience interacting with your doctor or your case manager pales in comparison to what you can do.
Yeah, but I
when
can
it's
fax him
convenient.
a report. So
I don't even have a landline anymore.
first question for the audience.
Thank you guys for the session. My question is, how much of the problem we face is what I call the lottery effect, where everybody who plays the lottery knows they're not going to win, but in the back of their mind thinks they're going to be the one to beat the odds. So in our case, you might be told that you have a risk factor for heart disease. You might see the data behind it, but you might still be thinking in the back of your head that you're going to beat those odds, and so maybe you don't have to change your behavior.
That's a consideration, obviously, and the term for that medically is resistance or ambivalence, and it's two different sides of the same coin. So almost everybody goes into that, at least early on. And just think of yourself. If you just received a call that your doctor says you have cancer, the first comment you will make is, that can't be true. I mean, think of it. That's what you'd say, because I've said that. When my father was diagnosed with cancer, no, that can't be true. It's our immediate response to it. But then you have to go through this acceptance phase, and it's a whole death and dying kind of approach. But yeah, that's part of it, but that's only a small part. And all of these companies try to nudge people through the resistance and ambivalence or denial phase, literally, in some cases. They just block it totally. But that's one of the steps of this. And the theories on behavior change really have studied that. So that's part of it, and it's definitely a big part of it. But once you get beyond that, which you can move people through that in a faster fashion than they would typically go through on their own, then you still have to do with what do you do next. So good observation. Next question.
Yeah, I'm
go
just
ahead.
going to add a quick things to this. When it comes to heart disease, there are very well-established risk factors that are known. I mean, there are literature, there are studies, like thousands of studies that says high blood pressure, high triglyceride, and many other risk factors. So the way we are modeling in our company, we are going through the literature, existing studies that have been replicated and validated, and model those risk factors when it comes to the non-genetic risk factors. So, and then we are comparing you with yourself having none of those risk factors. So we can just tell you how good you can do to yourself, not to the average population. Now, you might do all of those and still get heart disease. I mean, there might be some other risk factors out there that nobody knows, but we are trying to minimize the risk factors to the healthiest possible based on the definition that we have out there, based on the risk factors that are out there.
Now, your customers don't go into denial. They really want to have that baby.
Well, actually, I think that there is an answer that is relevant to that, though, because in the U.S., women, especially celebrities, are getting pregnant well into their 40s, 45, 46, 47. We see a lot of working women in particular who feel like, well, so-and-so got pregnant at 45 or 46. I'm 40 or 41. I still have a couple of years. I don't need to do anything about it. And then they're in our offices crying at 42 when, really the door has closed for them. And so they do experience a tremendous amount of denial at that part. There's like, well, there's no way that I can't have a baby. I mean, I'm only 42 years old. And, really at 40 is when really women's fertility significantly starts to decline. So they do have denial about the relationship of aging and fertility.
So the story is, if you want to have a baby sometime, have it now.
Well, and I also think the denial about egg freezing, but that's a whole other conversation.
Yeah, some of the other things that we've, just one more quick comment. Some of the other things that we've seen too, I think that's the challenge with preventative care. It's like, until something catastrophic has happened, do I have the motivation and the drive to change? But some of our best performing population groups have been in some of the rare disease states where if the patient's not managing it or taking an active role, like MS, for example, then very quickly their life becomes even more debilitating. And so that's where I think just where you hit that patient along that motivation curve or that spectrum is also really important, which is why we don't focus on content. We focus on another element of patient analytics to help distinguish you from me and from how I like to be engaged and talked to.
Next one.
Hi, my name is Liat. I'm from the MedStar Institute for Innovation in DC. Thank you for ending our conference on a high note. My question, you guys have kind of touched on it. Patients in different disease states with different health concerns have very different motivations. And in fact, a lot of patients are not motivated. You said they're not excited about their health. They don't see it as a priority. At the same time, we see in our country mental health costs really rising, right? And happiness levels reportedly decreasing. How do you guys incorporate mental health services into your thinking when you guide patients to health and trying to motivate them?
I'll start with that if you don't mind. The software that we have, the Avatar software, it's being used now by a big chunk of patients with MS, actually. And we specifically ask them periodically, what are your moods like? And if they give us an impression that it's not stellar, we'll actually ask them questions related to depression. If you look at the standardized tests for depression, anxiety, there's a whole spectrum of those that exist. They're very accurate by asking you specific questions and being able to measure your situation as it relates to that particular test. So if I ask you 9 questions about depression and you answer all 9 of those affirmatively, and there's a scale to each one of them, I can actually predict your risk of suicide as well as other things, and I can actually get changes over every week in that number are actually significant. We've studied these for decades. So asking the questions of people is very useful in determining some of their mental health issues. So, and there are other applications out there that are looking at this in different manners, and we were asked by the U.S. Army to develop something, and it hasn't been funded yet, so we haven't actually done it, but they wanted us to be able to take over the functions of the phone and call the base commander if somebody's suicidal, because 23 people per day, either current or ex-military, are killing themselves because of PTSD. And sometimes the only indication that that's the case is because somebody asked them, and we want to be able to ask them at any time of the day or night when they're on the phone with other things. So proactively looking at mental health issues has been shown to be effective in helping to prevent them. I don't know how you do it, but there are ways, and this is all proven. And I'd also highly recommend anybody looking at this, look at the literature. It's fascinating to see what other people have discovered, because there's a huge literature base out there on all these conditions. And obviously you've looked at that. That was the design of your algorithms.
We also don't, as you may recall, we are content agnostic, and that means we can deploy any type of content. So like Dr. Morrow, whether it's a standardized mental health assessment, whatever, we can put that down our platform and allow you to set triggers based on a patient's response for when you need to intervene. I think the one other important component about the way we think about the world is we still believe that healthcare is human care. And so while we're technologists, what we really focus on is enhancing the role of the care manager to be able to make those assessments on their own and to provide a better level of experience for the patient, not just purely a technology interaction. So by bringing more data back to the case manager, the care manager, about what's going on in your daily life between those 3 months when the doctor wants you to come back, we hope that whether it's mental illness, whether it's something else related to your chronic condition, that we'll be able to help you overcome that in a more timely manner than on your next visitation.
Next question.
Hello, I'm a designer with IBM, and the question I have is about the more publicly available and popular apps and devices like the Apple Watch and wrist devices and these connected fitness apps, fitness trackers that have been able to kind of permeate throughout the culture of today. What are some of the kind of like pitfalls and what are they missing to really kind of drive the public towards the, these kind of behavior changes that we need? What are they missing?
Go ahead.
Yeah, I'd like to answer that one. I think that, what you're defining is basically the quantified self movement. And it's probably the biggest craze and, one of the biggest things that are happening in technology and especially health tech. Everyone wants to quantify and measure how many steps you're having, how much you weigh, how many calories you had, what you burned, what you didn't. I think this is the first version, right? So we know now, okay, we have to collect, certain amounts of data, but currently, apart from Conceivable, I haven't seen anything that actually can take that data and use it in a way that can be prescriptive, that can actually help to change health outcomes. And I think that we're really underutilizing that data for the overall good of medicine, that we can really make significant differences in both men and women's health by capitalizing on the data that we've been aggregating, that everyone's aggregating by every piece of wearable device, Apple Watch, Fitbit, what you mentioned before.
The way we have used those devices for our platform, we have integrated the Fitbit and a bunch of other devices that we can track physical activity, sleep patterns, measuring some of the biometrics. And when you collect such data, you want to make sense of that. If I do more physical activity, if I control my blood pressure by 5 units this week versus last week, what that impact my health in this case? I read an article a few months ago saying that people who are using Fitbit, on average, after 3 months, they stop using it because I can just use it and compare myself with my friends and doing 500 more steps. One day is fun, 1 week is fun, but after a month, you're not going to make any more out of that. So, you have to make sense out of this data that you're collecting, whether it's about your physical activity, it's any biometrics, it's your sleep pattern. What can that do to your health in a daily basis and in a regular basis?
You asked a complex question. The first problem with the data that's being collected is it's not being collected on enough people. If you look at the health problems in the United States, there is a huge disparity in the health of different populations within the United States that's highly dependent upon socioeconomic status, education, and just where they were born, basically, and whether they had two parents. So we've looked at both sides of this. We were looking to develop an app for HIV. Well, what population has HIV? There's several, it's kind of bimodal, but one of them, literally, we're talking to a specialty pharmacy, and he said, they don't have phones. They can't use your application. Well, what if we gave them one? They'd sell it. Well, how do you deal with them? Well, we literally drive through town and look under the bridges for them to give them their HIV drugs. And, I'm thinking, wow, what kind of solution we have that's technology-based? They have no technology. They don't have a plug next to them. They have a street light that's on the bridge above them. So there are limits. And unfortunately, the disparities are going to be a limiting factor for all health interventions because they don't have the resources to do the right thing. But it doesn't relieve us from the responsibility of trying to communicate with them. And so we've got to go where they can be. And so part of the other issue is how do you actually maintain connectivity with somebody over long periods of time? And Prochaska clearly stated in his theories that have been proven for now 20 years that you eventually get to a maintenance phase where you don't need any interventions. I'm on a statin for cholesterol. I haven't missed it more than a dozen times in 15 years. I don't need anybody reminding me to do it. My brother, on the other hand, my younger brother, never started really taking it, and he died at a very young age. So he needed a whole lot more intervention in order to prevent what inevitably took his life. But we need to also build that into these algorithms, because, as you mentioned, one size does not fit all.
Has anyone here actually used a wearable or a at-home Bluetooth blood pressure cuff and actually had that data integrated all the way back to the provider's office? You or your family? Probably nobody. And I think I'm very bullish on wearables. I think anything you can introduce to a patient's life that reduces chores, that reduces any additional burden that someone with a serious chronic condition has to deal with already on top of everything else for managing their health, I think is going to go a long way. And I totally agree, this is the very first iteration, but the biggest problem right now is in fact a patient experience one. To actually use Apple Health with an EHR portal requires 3 different apps. You have your device app, you have Apple Health, and then you have your EHR portal. And for the average person, even me, the experience is terrible. And so until we get through some of those integration hurdles, I think that's going to be one of the bigger showstoppers to wearables and the Internet of Things actually being used in a clinical environment, apart from filtering and making sure that the data is actually relevant for the provider.
Thanks. I work for the Cystic Fibrosis Foundation, so adherence is extremely important to our patients.
Okay, let me break in here.
Yeah.
Cystic fibrosis 40 years ago was a death sentence by the age of 18 to 25.
Or younger, yeah.
Yeah, I mean, very, very quickly fatal. My son went to high school with a kid with cystic fibrosis that we were very concerned had a suicide tendency, because he was jumping off of bridges into cold water with my kids, and not really a very good influence. He's still alive at 42, or 40, I guess almost 40.
Yeah, the average life
So
expectancy is
amazing
40.
responses to that disease. Yeah. So tell us more about it.
Yeah, so lots of treatments and therapies. Now 2 new drugs that are directed at the underlying genetic mutation. Right. But we are also finding, because we certify clinics, so we get a lot of information from there, that people who have an emotional connection to their care team and believe that their care team really cares about them as individuals makes a huge difference towards adherence. So just wondering your thoughts on, great, we've got all this data, but how can we actually influence the intimate and emotional relationships that patients and physicians have with each other?
Quick comment, I do see and believe very firmly that the role of the nurse is going to increase and become much more important as health systems and ACOs have to be more involved in the patient's life. And we've experienced that with our own deployments. And I just want to reiterate that as a technology company, we're not trying to displace nurses' role and automate their job. We still feel very strongly that this is a human care business. And we just want to be able to provide more feedback to the nurse about what's going on in the patient's life to make that connection closer.
Well, I think that one thing that's really important to remember is that those relationships are very integral. I'm not sure that it necessarily has to be a doctor or a nurse. And so I actually think that lay people can provide a very wide spectrum of support. You see this in the fertility community a lot. I mean, it has to be moderated so that, there's not the culture evolves in a way that's actually supportive to the patient. But because the demand for physicians is going up and the demand for nurses is going up, and what Dr. Morrow was talking about this morning with us, the supply is decreasing, and so we have to look to our community and to the community of the patients to also provide some of that support, because sometimes those networks that get formed from people with like conditions can be very powerful if it's administered and moderated in the right way to keep the feeling and the sometimes what happens in those communities, there's a lot of unsolicited medical advice that's getting thrown away. So that's the main thing that has to be treated with caution, I think.
Well, and this may seem a little bit strange, but people actually develop a relationship with an avatar. And you wonder, how could that happen? Well, I've got 12 grandkids, as I mentioned, and 4 children. We absolutely are terrified if one of the kids comes over to stay overnight, especially under 5 years old, and they don't have their rabbit or their teddy bear. They won't go to sleep. They're so attached to that thing. It is a relation that even Nan and Pappy can't replace. So it's no surprise to me that people actually do that. And there's actually been clinical trials. There's an expert in Boston by the name of Tim Bickmore who created an app for patients, and he asked them afterwards some questions on a 5-point scale. How much did you think Sarah, and that was a computer avatar, cared about you? 4.5. Sarah cared. How can we measure care when an electron is moving through an app? I don't know. But people actually thought that computer system, Sarah, cared for them. And there was a whole number of questions related to the relationship that people could develop with it. And that's what is, in my vision, one of the next things to happen. And so think about creating these communities where you don't have to use people, because what she mentioned earlier, I've been studying this because my son-in-law actually is a resident right now, and he's in a world of hurt. 25% of all the physicians are retiring in the next few years. Enormous deficit. Same thing with nurses. So you don't have to worry about replacing nurses. There aren't going to be enough of them. And the more you can do to help augment them, the more their lifestyle will actually be acceptable to them. So we are facing a huge shortage of professionals in medical care. And it's all because of this baby boomer population is suddenly leaving the profession. And there are lots of other ways of trying to augment with that, like we've talked about today in our early discussion with telemedicine. But this technology that we're talking about here and that many of you are actually working on is probably going to be a part of the biggest forms of augmentation. So, next question.
Hi, my name is Amy Lee. I'm founder of Dance for Healing. So I'm a stage 4 cancer survivor. Started a technology company, tried to focus on home care for patients. It's an online exercise program through this live video platform that we built. So right now we have a program for Stanford Cancer Supported Care Program, and also setting up a clinical trial focused on this technology intervention, not only for patients as well as for caregivers. And so I'm very happy to find this panel, because we ourselves working with patients, and even myself going through this experience of cancer, find that behavior change, especially trying to persuade patients to adopt a new technology intervention. Well, first, adoption is probably the most challenging part. Like, people either, like, if they get on the platform, then they start using it. But the first step was kind of difficult. And then the other thing is, our program doesn't run the whole year. We're a small startup, so it's like one session for like 8 weeks, and then or maybe like certain months, and then that goes to like a break. And so how do we keep patients continue doing these and having sort of the behavior change in a more long-term sustainable way? I just love to hear what your guys' experience are like with your own patients.
It's very hard when you're a startup and you don't have a lot of money, right, to build enough content to keep continuity. But it's a worthwhile investment, apart from either just replaying the program from the first 6 or 8 weeks again, to have the people who are already engaged with your platform continue on. But my suggestion would be, if at all possible, to build more content so that and have that content layered in a way that they still feel like they're making progress, and also having, we found that having patients self-assess can also make a big difference in their engagement and overall use.
You know, when it comes to health or behavioral change, this is a marathon. It's not a sprint, right? We have been becoming lazier and lazier, let's just face it. We just want to have an app to do this for us. We want to have an app to do the other thing for us. And we want to have the health to do the same thing for us by just having a pill or taking one action, and this is just going to be enough for me for the next 10 years. It's not like this. So one of the areas that you can focus on to make people to be more motivated and engaged is to make this data and content more and more personalized. I mean, one size does not fit all. I mean, when I pitch this to our investors, our clients, they all say that, oh, I know that I should not eat red meat, or I have to do more physical activity, I should quit smoking. We all have known this for years, but look at the incidence of the diseases, and the numbers are just going higher and higher. The reason is because we are not making this as personalized as possible for an individual. I need to know the things that I need to face, not what is her risk or his risk. Making it more personalized to an individual would make them more motivated to be on that action and that route to be healthier or address those problems that can come as a complication or side effects for an existing disease.
I also think like app fatigue is a real thing now, right? Everyone has thousands and thousands of apps. And I think sometimes it's important to understand what is success for your business. And for us, we have a couple of key features in our platform, but it's okay, and we hope that this happens, that a patient comes through our system, learns some new behaviors, those that turn into long-term habits, or they digest some education material that's very impactful, and then they graduate. Now, where your program takes over from there, whether it's the health system's responsibility or you have another product line or something else additive to the experience, I think it's okay to realize that some patients are going to outgrow your system. I don't think trying to look for Facebook-level sustained engagement is really attainable. The other thing that we do, because of the limitations of creating content and the limitations of a disparate healthcare system, the people with comorbidities probably have 3 or 4 providers. And I guarantee you, even if they are all using Epic, they're not talking to each other. And they're certainly not using a startup solution yet at scale. So part of what we're doing is something we just believe fundamentally in, which is empowering the patient to kind of transcribe what 3 or 4 providers may be telling him, even if all 3 or 4 of them aren't using our software. So trying to transfer some of that trust back to the patient to go, okay, what's happening and what dialogue you're having with provider C, go ahead and plug that in so that provider A can have more visibility, effectively giving patients control of their care plan.
Wait, are you suggesting patient report their conversation with their physicians?
We are enabling patients to basically close the interoperability gap if it's not already there by taking what a doctor's telling them to do and putting them into their own care plan, but providing that visibility back to provider A who is using our software. Does that make sense?
Yeah, okay.
Well, the way I see it is, what does the patient need, or the person who's using it, that he doesn't have an easier solution for? And here's for instance. We have an application that's being used for an injectable medication for multiple sclerosis. The injection's given either several times a week or every day. And it has to be rotated through about 100 different places on your body. Now, how many of you remember what you ate last Wednesday for lunch? No one. How could you possibly remember when you injected in this part of the arm when it could have been 100 days ago? So we have we have an enormous number of the people using it saying, where do I inject today? Done. That's all they ask us. And we then say, well, tell me when you've had your injection so I can record it. And we also then initiate conversation. And this is verbal as well as on just the image, like a typed message, of how are you doing? Is there any questions you have today? How else can I help you? How are you feeling? And these aren't asked every day, so we put these in various time periods. But we also ask various questions that they want to measure. Their functional status. MS, as you mentioned, these folks are in a world of hurt if they continue to progress. How do you measure progression? Well, there are tools to measure that. It's a tug test where you timed up and go. And we can also measure how much activity they're doing and give them an attaboy. So what keeps your dog coming back to you? A pat on the head and a treat. So it's no different with humans. Behavior is always repeated if it's rewarded or if it's rewarding to have that behavior. And so think of ways that you can incorporate those types of functions in your application. But go back to human psychology. I know it's really boring to read psychology textbooks. I've read several of them and outlined them for our developers. It is like eating cornflakes with no milk. Trust me, every day, all day. It's horrible. But the fact is there's an enormous amount of knowledge already gained in these textbooks. And start looking at how humans think, how they behave. And also pay attention to their subconscious behaviors, because most of the things we do, we don't think about. We just do it. And anybody that doubts that, think back when either you were this age or when you had a kid this age. When I asked my 16-year-old, what were you thinking? He said, I don't know. And He didn't know. He wasn't thinking. So we don't think for most of our activities. In fact, it's physiologically impossible for the brain to get enough energy to actually make a decision about everything we do each day. It's all subconscious. So think about how you can help the subconscious to deal with some of these issues.
Yeah.
Other questions?
Very helpful. So one comment, I just wanted to go back to your personalization. We actually did file a patent for personalization, but at an early stage company, it's difficult to actually build that recommendation engine. But over time, and then there's also this sort of huge time and investment to try to figure out how to integrate like the sensor data and all that too. And the other thing was really interesting is I'm actually sitting in a Stanford D School's class called Design for Healthy Behavior Change. And what's really cool in the class, they have students pair up as a buddy system, and then they do a personal health project. They help each other and kind of build that empathy, like to realize how difficult to do behavior change. And they get paired up with one of the Stanford patients and help them create behavior change. And so at the end of the class, a lot of these patients actually did create sort of major behavior change, which is very encouraging. So one of the things I was very curious about is they have like 2 students working with 1 patient. And most healthcare, like us, like we have 2 people working with 50 patients. And what I find make them successful was this sort of deep dive into patients' motivation and really understand their goals and what really matters to them. And I'm trying to figure out how do I possibly scale these kind of methodology, which takes a lot of in-person time and dedication, to kind of scale that in a large patient populations.
I think that is the challenge with deploying technology in the healthcare environment, because traditionally it's a huge liability to make any mistakes. But when you look at the way consumer software is often developed, it's shipped really early, it has lots of bugs. But the important differentiator is we're testing this product at a pretty meaningful level of scale. We're not doing it in a in my opinion, statistically insignificant clinical study of 10 patients. Like, that's not representative. And so that is the problem, I think. And I'm hopeful that with some of the movements in FHIR and interoperability, that we're going to be able to empower health systems to be able to pick a handful of apps and deploy them with a lot less friction than what is involved today.
Great.
So I don't have an answer for you. I just acknowledge that is part of the problem.
Yeah.
Yeah, thank you.
I'd like to ask go ahead. There's another question.
Hi, thanks so much. This is really interesting. I work at a company called Ideas 42. It's a behavioral change, innovation, and design firm. And one of the projects we're actually working on is trying to encourage people with prediabetes to join the National Diabetes Prevention Program. And one thing we have seen is that the role of other people really makes a huge difference, right? On one hand, it's a channel that if other people are motivating them or will do the program with them, then they are more likely to do it as well. But on the other hand, if their family doesn't want to start to eat healthy, or they're kind of in a context where other people aren't making those decisions, it makes it much more difficult. But with technology, it seems inherently that it's like you and the technology, and kind of everyone else is outside of that picture completely. So in your experience, has there been any way to kind of bridge that gap in using the technology to also figure out the channels and bottlenecks that other people around them have, the influence they have on these behavior changes?
Go for it.
Okay, so first of all, you're dealing with what's called the classification of social cognitive theories. We are herd animals. We like being around people. We like telling our problems. Despite the fact that HIPAA exists, I had heart surgery a couple years ago. Forgive me for telling you that, because I've just broken every HIPAA law in the world if it was about his heart surgery, which he didn't have, as far as I know. But the fact is that we don't mind talking about our problems as long as they are not socially stigmatizing. And groups do better than individuals. So the companies that are trying to build applications where they bring in teamwork or competition or the ability to talk with one another, and we're in the development phase of some of those components of this, are going to be much more successful than if you try to do it just all through an app. Because we look for that. There are companies out there like Patients Like Me that have an enormous following because of that. And obviously, if you want to look at a whole lot of medical problems, look through Facebook, for crying out loud. I mean, everybody's talking about everything. My daughter-in-law had a hysterectomy, and she's telling, all through Facebook, because all this stuff about it, their hysterectomy. My parents would have never talked about that. Nowadays, we're much more open with that. So why not build that into your software? And because that's a powerful motivating factor.
Yeah, I agree. And just an observation to your comment. So at the first Health 2.0, there's only really been one startup that has actually survived the last few years and continues to show up, and that is in fact Patients Like Me. So if that's not a testament to how hard it is to survive in the healthcare industry as a startup, but also to your point around the value of communities and patients exchanging insights and things that are happening for them and what's working and what's not, that is a very powerful component of it. And we also, in our own platform, focus on the family as a continuation of the care.
How about you? I mean, do you have a program that allows that type of?
Yeah, so Conceivable is not even a year old yet, and so that's definitely in our roadmap for building in-app communities. Glow, which is a fertility tracker, has built an enormous 3 million patient fertility community there that we participate in. I think one of the things that can be really useful also is to sort of have periodic experts in those communities, sort of answering questions and not necessarily giving medical advice, but answering frequently asked questions about medications, about protocols, about whatever's coming up for them. Because often when one patient has a question, many other people have the same question, and frankly, people are not always comfortable asking their physician the questions. They don't want to feel like the doctor's going to think that they're stupid or that they should know better or that they could look it up online. So I agree. I think that communities are one of the most powerful ways that we can use technology to actually bring, especially when people have diseases that are very rare, not necessarily in the fertility space, but in other disease spaces where people might not live in a city where there's other people with cystic fibrosis or certain specific kinds of cancers.
Just to add a quick comment, one of our customers is a corporate wellness company. They have about 800,000 members. They are actually going to different employers and onboard their employees, and they have this grouping pieces of competing between one group of employees with the other ones, and they are using our platform because they want to identify who are the high risk group of people that they can put together, because we are not going to get to this engagement gamification of that whole thing, but there are companies that are really strong on that user interface and gamification that we are working with them, and they actually get a lot of attractions and feedback and involvement from what they have as tools.
Let me build on that. I did an enormous amount of research earlier this year and wrote a series of articles about how none of us are going to solve this problem. All of us will solve the problem. And the idea of incorporating for parts of your population, her application and her technology may be ideal, but only for a small portion. And for others, his may be ideal for helping with the communication. And so the idea of each of these little startups being the solution isn't going to happen. It's going to take the connectivity of what has been termed by it's a medical director at Kaiser. He called it the Plico system. And it's a platform of systems that are connected, and it's integrated. So think of how you can somehow latch on to other people who are doing similar but slightly different things that would work together. Because that's how we're going to solve this. It's not going to be one system. It's going to be a system of systems that are tied together.
Last question.
It's me again. So this is great because you guys are really building on what I was coming to ask.
For the grand finale.
Yeah, right. So there is someone who has no issues asking questions about my health, my mother, right? And I think that we all find that family members are sometimes the best advocates for our health, right? Much more so than we are ourselves. So you kind of touched on it, but I'm wondering what your thoughts are on engaging family, not just other people like me, but people who really love me and care about me. And then also, how does the startup community do that, but also how can a provider organization, right, because we're no longer talking about one-on-one providers, we're talking about huge complexes of providers, how can they target broader families in patient care?
While we know that patients' families are integral to their success in whatever their health, struggles might be, at least for technology, the HIPAA restrictions make it almost impossible currently to do that. I don't know if you guys have had any success integrating family behaviors.
Well, we actually had a conversation with one of our applications. This is talking to a computer now, so this isn't talking to me. This is talking to the agent. And the lady says, Claire, my daughter wants to stop her birth control pills. Is it acceptable to stop her medication? Too, because she wants to get pregnant. And the agent then says, you're not the patient, are you? And the agent was smart enough to know, I can't answer that for you because it's stupid, but the computer couldn't even answer the question because of HIPAA. So we're going to have to get through that. So, and we've kind of designed a way that you can actually add on people to be able to talk to your agent about your health. But it's a regulatory issue more than a technology issue. And once you work through getting the technology to comply with the laws, then it's acceptable. And when I go into the doctor's office, I have to sign a paper. Who else can hear the voicemails besides myself? I always put my wife down. I really don't have too many secrets from her. And so why can't we do that with the application? There's no reason we can't.
They're giving,
Two quick comments, and then I think we have to wrap up.
Yep.
they're wrapping us up right now,
Cool.
actually.
So one, in our solution, we actually hold the privacy policy with the patient directly. So we're a very patient-centric company, which enables you to opt whenever you want to share it with the family or not. Number two, again, not everyone wants to share their data with their family. My mom's already complaining at me about not being married and not having kids. The last thing I want to do is complaining at me about my health care. So we leave that decision up to the patient, and we get through some of the HIPAA hurdles by having that relationship directly with the end user, as opposed to expecting the health system to facilitate all the stuff you have to do to get through the HIPAA issues.
They're going to need the room immediately after this, so if anybody has any questions, we'll step out in the hallway, and then they can turn the room around immediately. Thank you,
y'all.
everyone. Appreciate it. Thanks for sticking it out to the end with us.